a real pleasure today to introduce two friends and colleagues from across the health system, Tom Owens and Jonathan Bay. This talk is important for a number of reasons, and I'm hoping that not only the people in the room engage in this discussion, but maybe folks who are viewing follow up with Drs. Owens and Bay to continue the dialogue they're going to start today with us about the last mile. So we all want to improve healthcare, but one of the hardest parts of actually improving care is on the front line during that last mile when care delivery actually happens. By way of introduction, I'll go through a little bit of each of their bios just so everyone is sort of introduced to sort of the wonderful work they're doing. Tom Owens is Vice President for Medical Affairs and Chief Medical Officer of the health system and an Associate Professor of Medicine and Pediatrics. He received his MD with honors from the University of Buffalo prior to coming here for his internal medicine residency and pediatrics residency, followed by a general medicine fellowship, as well as a chief medicine year. After that, he rapidly rose through the ranks, holding a number of increasingly significant medical leadership positions within the health system over the past 10 years, and now he oversees the medical affairs throughout Duke's network of hospitals, clinics, and other evolving population healthcare settings. In 2013, the health system launched a transformative program to address the changing needs of patients in an evolving healthcare landscape, and as Vice President of Medical Affairs, he leads the clinical operations programs and care redesign efforts of this extensive project. He's also received numerous awards and honors along the way, including several teaching awards, the Eugene Stead Award, the Samuel Katz Award, as well as the Duke University Presidential Award for Executive Leadership. Jonathan Bay is the Associate Chief Medical Officer of the Duke Health System and an Assistant Professor of Medicine and Pediatrics. He received his MD from Virginia Commonwealth University after being an undergrad here at Duke, and then returning for a combined residency in internal medicine and pediatrics, and has also served in several key roles in quality improvement and patient safety, including as a chief resident for the medicine residency program, associate program director for quality and safety in the medicine residency program, as well as associate medical director for quality for hospital medicine. He's a hospitalist and focuses on hospital-based performance improvement with a special interest in mortality, patient safety, care transitions, and medical resident education. Just recently, December 2015, he became the Associate Chief Medical Officer for our health system, and in this role, he will help set the quality agenda and coordinate patient safety and clinical quality activities across the clinical enterprise. Both of them will share with us their current quality infrastructure within the health system, as well as various challenges and opportunities to improve the quality of care locally. Please join me in welcoming both of them.
Thank you. All right. Well, thank you all for the opportunity to come and talk today. I certainly want to echo some of what was said up front. I'm really excited about the opportunity to come and talk to a group here at the DCRI. You know, we're going to talk today a little bit about the quality efforts through Duke University Health System, talk about where we are and hopefully where we're going, and as part of that, some opportunity for collaboration. And this conversation couldn't be more important than it is right now. The healthcare landscape is changing rapidly. There is a real revolution taking place as the amount of recommendations that needs to be incorporated into our practices, or as there's increased focus on population health and increased emergence of new technologies and solutions, and trying to figure out how to incorporate that into a patient population that's becoming increasingly complex as the volumes are increasing is really the new crucible that we're bearing. And so what better time than to come and talk to people who are really focused on excellence and innovation in research and knowledge sharing as well as translational medicine. So we're really excited for the opportunity. I'm also excited because this is, I guess, technically the first talk I've given as the Associate Chief Medical Officer. And I'll say, I guess, the first task of that is to come and give a talk. So that's really, really exciting to be here for that purpose. So a couple of key objectives we want to attend to through this talk is, one is just describe the current quality infrastructure for those of you who may not be aware of what it looks like for the University Health System, to describe some of the current performance and how we measure ourselves as part of that. We'll also describe and enumerate some challenges that we face moving forward. We'll give a brief overview of some key targets and strategies that we're deploying, and then again really hit the highlights of where there are opportunities for collaboration and continued partnership. I think it's probably a reasonable place to start to talk about what is our overarching goal and mission here. We look to set priorities to drive much of this work. And I think it's really timely that recently released by Chancellor Washington was his strategic framework for planning to reset the vision for Duke Health, to be one of advancing health together. And underneath of that, there were a couple key visions that were outlined, including delivering tomorrow's healthcare today, accelerating discovery and its translation into clinical practice, really working to create education that is transformative, building healthy communities through population health and management, and then trying to connect with the world and improving care globally. You know, when I look across that vision and as part of our values, quality and quality improvement and all of that entails really extends across all of that. What also strikes me is how important it's going to be to work together. This is not a vision that can be delivered upon by one single person or one specific entity or clinic. This is going to require all of us across the clinical and academic enterprise to do. So obviously there's a tremendous opportunity to bring people together and start having this conversation. So let's cascade it down just a little bit to describe, well, what is our clinical enterprise? What does it look like? What is Duke University Health System? And it's made up of 5 principal entities, the 3 main hospitals, Duke Regional, Duke Raleigh, and Duke University Hospital, as well as Duke Primary Care and Duke Home Care and Hospice. Through this organization, we have over 16,000 staff, close to 2,000 clinical faculty, and approximately 1,000 GME trainees, including residents and fellows. And it's through their combined efforts that we have over 2.4 million outpatient visits a year, over 160,000 ED visits a year, over 65,000 inpatient admissions across our 3 hospitals, and over 90,000 surgical cases a year. This is just the highlights. This list could go on and on and on. All told, Duke Health manages and touches 750,000 unique lives in the area. What a tremendous footprint we have to really change and lead transformative care for our patients and our population. So how do we coordinate that? How do we set a vision? How do we start thinking about what our quality actually is? And we look to how do we even define quality? And for the Duke University Health System, we define quality much in the same way as the Institute of Medicine did back in 2001 through their report, Crossing the Quality Chasm. And in that, they outlined 6 key areas of focus for quality, namely that it was safe, timely, effective, efficient, and equitable. And most importantly, patient-centered. And that's the thing which I want to make note of is here we really try to put the patient in the very center of all of the type of quality that we're delivering. As we move forward into thinking about, well, what are the principles that drive our commitment to providing the highest quality of clinical care, that's patient-centered, efficient, effective, and so on, how do we set that up so that it really permeates through all levels of our organization and to all of our clinical operations and so on and so forth? And part of that drive to create that core mission is set up through 3 principles, which is leadership, performance improvement, and a culture of safety. Leadership is the set standards by which we drive some of the accountability for sure, but also really help to set that culture of safety and to create the drive towards continuous improvement and service excellence. Performance improvement is how we deliver upon that through some of tools and strategies for data review and management to understand where are there opportunities to improve, how do we compare to other institutions, how do we compare nationally, and then identify areas for us to deploy and prioritize where can we deploy efforts to do better. And all of this is in the environment of the culture and safety, which again is really set by the leadership, but defined by our people and our workforce. It's the teamwork, it's the safety culture, it's how we communicate and how we have mutual respect for one another. And these are the 3 kind of core principles that drive our health system's commitment to quality. There are many, many, many ingredients that drive this. We think of this in a tiered approach, and this is a framework which I pulled out of some of the strategic planning that took place this year, which I really think describes what are some of these key areas. And I'm not going to say that we are perfect in all of these elements, but this is how we at least conceptualize it. There is a foundation, which again is driven some of which by our leadership culture and the comprehensive culture for safety across the organization and quality. That we have in purposeful actions toward patient engagement through patient advisory councils and the like, through staff engagement. We have a commitment to organizational alignment such that as we are identifying areas for opportunity to improve, that we try and cascade that down through the organization. Moving up into what's the infrastructure that supports that? Well, some of that comes through the way we've defined our clinical entities, namely the hospitals, into work units and so on and so forth, and a management system there. Through interactions with folks within performance services, which allow us to identify and again move and do process improvement. And part of that also includes meaningful measurement. And I think, again, that's where, as we are moving into the next phase here, and the next wave, where again, there's really some opportunities for collaborative efforts. And all of these foundational elements and the infrastructure to support leads to the goal of setting and driving a new standard in quality and safety for the health system. And as we continue on our journey to try and become to continue to be a high reliability organization with an increased focus now on patient-centered outcomes and population health. Okay, so this is a really busy graph, and I apologize. And you're never supposed to put a graph up that nobody can read. But I wanted to show you that this is an incredibly complex structure, but that does have some general cohesiveness, which allows us to coordinate this. As an example of how important quality is to our organization, these operations flow directly up to our senior leadership as represented by Dr. Owens, as well as Dr. Fulkerson, who's the Executive Vice President for Medical Affairs, as well as to the Chancellor of the health system. This work then can roughly be thought of moving from left to right on the screen as more external facing to internal facing. We actually have a tremendous footprint within the community through our Duke LifePoint network and community-based hospitals, where we try and take our message of quality and help translate that onto the community. So again, continuing to extend our brand of quality to other organizations. Internal to Duke, we have the Duke Patient Safety Center, which is here in the middle bucket. And that's where we house a lot of our training activities around resilience and teamwork and patient safety. Some of the simulation is housed there. We also have our patient advocacy groups are housed in this group. And the Patient Safety Center does both external facing, where we do a tremendous amount of training for teamwork and resiliency, both externally as well as there's an inward focus. And then on the right side of the screen, which is actually the area that is most focused on the inward parts of the organization. That's actually the area that I most directly oversee, and I was a little dismayed to see that I had the most buckets underneath of me, but that's okay. I'm happy to do this. This includes a combination of both performance services and clinical quality oversight, as well as oversight of our patient safety operations, to really be a more cohesive approach to combine them, to bring them together, to have a coordinated message that goes downstream to staff and entities. So that is a very complicated structure. I'm now going to pass the microphone off to Dr. Owens. Oh, you're going to say, okay.
Thanks, John.
Absolutely.
So I had joked before we started that I only use a handheld mic to sing. So if I do break out in song later, it's forgive me. But thank you all again for having us here today. It's great to see some friends and faces I haven't seen in a while in the audience. And I commented also before I last really spent a lot of time in this room back when I was doing the CRTP program back in the late 90s. So I have a lot of fond memories of spending time here on the lower level of North Pavilion. So it's great to be back because, as John said, this is a phenomenal time for us to think about how we can organize ourselves differently. And I wanted to come back to that message and just backtrack briefly on this slide, because I think John understated the role he and others have played in helping us think about how we're currently organized to manage quality improvement, and organized to better interact with folks like you all, with other individuals and entities around Duke Health that can really help elevate our performance, help us lead nationally. And so in that very busy box on the right-hand side as you're facing this, you know, many of you know we've had a long history of performance management at Duke with folks with an industrial engineering background hired into our performance services team. Many of you may also know that those great people have been fragmented and organized in pockets around the institution and not really collaborating, often duplicating efforts, often not working in the same way. And so part of the foundation work that's happened over the last year is to create a new team, basically a new reporting structure, so that all of those performance engineers, those folks that help drive some of our performance improvement, are now under a new director, Jennifer Rose, who's a phenomenal leader to help us do that, who works very closely then with John and I, that are patient safety officers that, again, help us look at one aspect of quality of care, and those specific events that may lead to harm for our patients have also been organized with reporting up through their entities, but also now in a collaborative relationship, so that we're sharing much more information now across the system. And similarly, across some of the other things, we'll highlight a couple of these tactics we've deployed. We're trying to think and act as a system. And for those who've been at Duke for a long time, you know, we've been a system in name for a long time. I would argue we've not been a system in the way we manage and in the way we work for a long time. So we need to make some progress on that. So what I wanted to spend just a very brief moment on and dazzle you with a few slides here to give you a sense of how we've struggled to measure and how I think we need to measure going forward, which I think are somewhat different things. So, again, many of you know we've had a management system in place that works from priorities that are defined within the organization or sometimes outside. Sometimes it's CMS or the state or others that are saying we need to measure X, Y, or Z. I'll tell you, it's often for the things that we measure, it's often an external force that's telling us what we need to focus on. And we work through then a process of identifying how we measure that, what data elements are available, how meaningful those are, or how valid they are. We often put in place, much in the work you do, validation processes that are extremely labor intensive and challenging for us. And then we manage, monitor, and improve based on this. And this is a model we've had in place at Duke for more than 15 years on the clinical side. And it's worked fairly well. This highlights some of what I was saying about how we identify those strategic priorities for us to measure. But what this has left us with, and again, some of you will know this, is before we went live with Epic, we had about 1,900 management reports that were in production, that were being used. You might imagine that not all 1,900 were being used effectively or regularly or understood. So we attempted during that transition to cull the number of reports and focus on the reports that were of highest priority, of biggest impact. We ended up with some 1,100. So probably did not really do a great job. Now, I pick on the reports, but some of these are actually useful for management, and I'm not going to go through the details of this, but I think many of you are aware that we've used a management tool called a balanced scorecard, which basically focuses on areas of the business that we think are important. And this is a snapshot of the Duke University Health System scorecard. This is a real deal scorecard. You see quality and patient safety is first on the list. It is, I think, most important, and it is what we talk about first. Patient experience is next. As again, all of you know, we color code, and it looks like Carolina blue here, but it's really Duke blue is best. That means that we're top decile performers. So in the top 10% of our peers, and we define peers as our academic health system peers around the country. Green means we're better than the top quartile, which is generally a meets. Yellow is we're not meeting. We're between the median and the 75th percentile, and red is we're below the median. So our goal is not to have a blue scorecard, actually. It's to have areas that we focus on. And you see here that we do have areas to focus on. And again, the numbers aren't so important, but one of our challenges when you go through these, and these are high-level summaries of those scorecards across all of our entities, is don't focus on the performance, but focus on what we're measuring. Mm-hmm. And think about how that translates to clinicians. And I know we have a number of clinicians and folks involved in clinical care in the room here. So we're measuring things like evidence-based care for venous thromboembolism, which, while it does have some important elements in terms of are we preventing a life-threatening event for patients, falls short of actually measuring real quality of care in a lot of ways. And if you walk down many of these, again, some are very important, but I'll use mortality ratio as an example, something we care a great deal about, the survival of our patients and the outcomes. This mortality ratio only measures inpatient mortality for our patients. So it really doesn't accurately reflect the total picture for survival for our patients. So across these measures, and I'm going to show you a couple more of these. This is one around patient experience, which probably is a more valid measure of patient experience in a lot of ways. You'll see that what we've been so focused on to date have been those externally mandated or required measures. And I don't mean to minimize this because that is necessary. It is actually, first off, a requirement to participate in CMS, to be paid for Medicare and Medicaid services. It's important because these measures are often used in rankings, and I'll show you a quick snapshot of that in a minute. But again, it falls short, we believe, of defining who we are and setting the stage for how we want to deliver care going forward. And so we want to really push the envelope and think, again, with partners like you all, about how we might define some better measures that we could use to really drive care delivery, to work with our teams to improve patient care. I'll just show you now that we actually measure things across the continuum more now today than ever before. So this is our primary care dashboard, and these are HEDIS measures you see down at the bottom, which many of you are probably familiar with. These may be actually some fairly good measures, although again, there's some limitations that we may come back to and talk about this. But we actually do pretty well in many of these measures, just as in the inpatient setting. So across these HEDIS measures and several others, we are in the top 10% of organized health systems in the United States in our performance. So that's something to feel good about. I'll tell you, we've been in the top 10% in this category for 3 years. So part of the driver in ambulatory care, like primary care, for needing other things to measure is we want to expand and look at other areas of practice and make sure that we really are improving care delivery. Similarly, this shows just hospice. Again, you'll see the diversity of these measures that are out there. So where does this leave us? Well, it first off leaves us in this landscape. If you look across the publicly reported measures, some of which you see here are CMS in that middle column, some of which may be used by groups like US News as a way to provide, in their opinion, consumers information on where to seek health care. In other people's opinion, their ability to sell advertising and other things. Truven, you see here UHC, we have Leapfrog on the end. We have a couple others on the next slide I can show you. You'll see that there's a lot of eyes looking at us through these publicly reported measures. So we have focused on a lot of these. You'll also see that there are different measures included in every different ranking. And so it is almost dizzying when you think about how to manage to this. And these show for our accountable care organization, the current measures, and for Blue Cross Blue Shield. I will tell you that, that in our current book of business across the health system, it's only about 3% of our total net patient revenues that are at risk right now for quality. So it is a fairly modest amount of money. As probably all of you know, the average net margin for most health systems in general runs in the mid to high single digits, so 6 to 7% is not a bad operating margin. So 3% actually could be the difference between a good or bad year in some ways. But there's not a huge amount of our annual revenues that are at risk right now, but still very important. So again, the main point that now I'll just quickly show you. So this is our current performance in US News. And again, I don't really want to dwell on this, but just say that historically, a lot of our emphasis has been managing some of the measures that are of value here. See, again, we do reasonably well, although we've actually fallen in these rankings a little bit. And this is the Leapfrog scorecard, where again, our hospitals overall do fairly well. So we've proven we can manage to some of these measures. But coming back to, again, the challenges and starting to tee up some of what we'd really like to talk about with you today and what, again, we hope is an ongoing discussion is, we have been going down this road of many of these measures, many of these targets for performance now for a number of years. And we've recognized a need to focus differently, to actually work with and listen to our providers in ways to help us understand how should we be measuring quality, what are areas of focus. So some of that is clearly around better metrics, better measures, and using some of the information that's, the knowledge that's generated actually through our research enterprise, through work that we do in national collaboratives to help both drive the external landscape of measures so that we can focus on what we think matters most, but also create the bandwidth and the infrastructure to have internal measures of success that we strive to achieve with the same vigor and the same intent that we do for those external measures. Balancing that is the challenge. As I already said, we have too many scorecards already, too many things we're managing to. And so how do we prioritize and focus appropriately? And how do we meet the growing demands on our data systems? How do we ensure that we have actionable data that's entered into our electronic health record and other data systems and not burn out our clinicians in the process of ensuring that those data are actionable and accurate? And then another real challenge in this mix we face is the push for efficiency in healthcare, where John showed our numbers. I was meeting with our primary care leadership team this morning. We'll probably see about 720,000 visits across Duke Primary Care this year. That's up from 540,000 2 years ago. That's pretty dramatic increase. And we're on a path to see 1 million ambulatory visits across Duke Primary Care within 3 to 4 years. So as our scale grows, as the pressure within each area we deliver care grows to be more efficient, how do you maintain the same focus on quality and measurement and management systems to be able to do that? And so some of that comes back to defining new models of care, new ways of care delivery, and focusing on as we've talked about with Will and others, how do we create living laboratory environments where we can test new ways of care delivery effectively and then scale those? So John, I don't know if you want to hit on some of these, but we see a lot of things that are listed here, but you'll see that generally in summation, they mean that our business as usual model needs to change pretty dramatically if we're going to continue to be successful.
Well, and I'll just reemphasize. I mean, a lot of these things all kind of hit back to the metricing we put around this, and the emerging kind of conversation around metric fatigue and how all of this is starting to impact workforce resilience. We're seeing more and more. How do you prioritize that and create a process to identify where do we need to have the highest prioritization and then allocation of resources when oftentimes those don't exist or spread thin. And that's part of where some of the conversation happens around the data management and data analytics and where do we look for partnerships across the academic enterprise to say how can we start thinking about this in a different way, particularly as not only do we need different measures for the providers, but we need different measures for the patients and more increased focus on patient-centered outcomes and patient outcomes in that way. The one piece I'll say just as a reflection on this, as Tom was showing our performance, is even engaging with people across the health system and saying, how are we doing? How do we measure up? And one of the things that really struck me, and I was one of them, is when one of the first questions we were asked was, well, do we think that our quality is high? Now, of course, that's a big debate, but how do we define quality? And the overwhelming lens that group brought was that no, our quality could be better. It's not. But when you look at how we perform, actually, we do quite well from a certain point of view. And what I think what people are clamoring for is all of this, is to say that there is an opportunity to say that, well, we're doing really well with the things that we're reporting right now, but things are going to change, and we need to be ready and proactive around that. And how do we start planning for that future?
That's very fair.
Okay. So I think with the next little segue here, and Tom and I will pair off for these, is to talk just about kind of some examples around the organization, just real high level of some work that's happening. And again, thinking about, as you're seeing some of this, where there's going to be opportunities for potential collaboration or how we could focus. This roughly looks at what our 5-year safety and quality plan was, and it's likely going to change or evolve over the next couple months. But there's a couple big buckets of which we start to think about what are the quality issues or quality priorities, and that boils down to quality, the culture of safety and quality, patient safety itself with harm reduction, clinical quality and value, population health and management, and then patient engagement experience. And under each of these, there are work streams and data and activities happening around the organization that span the spectrum from inpatient, outpatient, and across the clinical entities. I'm not going to go into all of these. I do just want to say that there is a tremendous amount of work that's happening already, some of which, the truth be told, is already being supported by some of the people here. So this is where we want to continue to grow these. I will say that we're going to highlight over the next 15 minutes or so a couple of these buckets, which I've lumped here: mortality and voluntary reporting, and then let's have a brief talk on care redesign as well as population health as examples. So let's talk about voluntary reporting, and I'm going to a degree, link together our voluntary reporting and our safety structure with mortality as well, because I think when I think about the landscape moving forward here and where there's some opportunities, that they're somewhat similar. So we have actually been using a voluntary reporting system for safety events for the last decade, and a lot of this actually with an electronic system that was originally pioneered, I believe, by Jeff Ferranti, who's now our CMIO. And over the last 2 years, we've actually noticed that we've had, similar to our EPIC journey, a number of disparate systems related to risk management and our safety reporting and patient grievances, that we wanted to bring them together for a better idea of how do we coordinate this across the system, how do we have kind of more of a same enterprise-wide platform for this. And that is what ultimately became our RL6 platform, which was a new solution for safety reporting that went live about 2 years ago at this point. And I just want to give people a snapshot of what we're actually dealing with with the patient safety officers across the organization around the volume of events that we're seeing. So this is last calendar year, January to December. And over that time frame, there were over 24,000 safety events submitted. Now, not every single one of those led to harm. Actually, 600 of those events were ultimately classified as harm, which is roughly about 2% of the month-to-month. And there is a robust structure, which we alluded to in some of the prior slides, where this data is managed by the patient safety officers at each of the entities, and they have a process to classify and to go through and really identify opportunities for improvement. Where are things where we can do better? Where are there things that are thieves? And then how do we use that then to be more proactive to prevent these things from happening again? And the data is actually really pretty robust in a way. You can classify the event types. There's 22 event types underneath of the primary one. And then underneath each of these separate event types, medication and fluid and lab and specimen are our two top hitters. You can actually subdivide and go down further, and then actually group these at the health system level, the hospital level, all the way down to the unit level. And you can see that we have 22 general event types. About 4 or 5 event types make up over 50% of what we see, and about 6 of the event types make up over 80%. So there's a lot of energy and focus down here. The top 2, as I said already, are medication and fluid and lab and specimen. Actually, there is a tremendous amount of activity driven by our clinical pharmacists as well as through our lab. To really explore that. But some of these areas, for example, provision of care, which tends to be much more of a catch-all bucket, or there's a diagnosis group, or there's a surgery and procedure. These are areas where we're spending a lot of time within our governance to say, well, how do we use this data? How do we make it useful? How do we use it to actually prevent things from happening? How do we be more proactive with that? Because we have, in the end, 600 patients that were harmed each year. How do we get that number to 0? That's a tough thing to do. Yep. No, these are, if you take all of the event types here, or excuse me, all of the events that were entered through our safety reporting system, which is RL, they are ultimately grouped into a single category, i.e. either medication, lab, specimen, and so on and so forth. So this is that 24,000 events now over the last calendar year grouped into event categories.
Just events that were reported as safety events.
Correct. Correct. Not specific to mortality.
And even here, when we talk about events with harm, there are a small number of events where that event, that wrong medication, fluid administration issue, failure to diagnose resulted or could have contributed to the patient's death. That is an even smaller number than 597. It's actually, you could count it on one hand, actually.
Yes.
The intent being to really identify patterns of errors or patterns of problems that are the canary in the coal mine that might indicate a potential risk to cause more severe harm.
Yes, and and actually, it's where there's robust process in place. For example, I'll use lab specimen. I saw a recent presentation by our lab, who had really dove into their data, and they subdivided the lab signal here, and they found that 2 of the biggest categories were related to transport issues for specimens and related to the identification and labeling. And they were able to real drill down and find performance improvement opportunities around, well, there are certain areas that were labeling specific specimen types in a way that was not allowing us to make sure that we had the right sample. And so they put in place a performance improvement strategy to improve that. Similarly, they found that there was leakage of certain sample types. It was urine. That was the primary sample tube that was being collected, and so because of that, we put in place a strategy to change the urine sampling collection tube and have seen a decrease in that. That's how this data can be really powerful. Medication safety does something very similar to look for anticoagulation events and insulin events and has work streams based off of those things. That's the potential power of this system, of which I feel like we're only just grazing the surface with the amount of data that we come in on a month-to-month basis.
John, would it be fair to say that we struggle with more complex analyses, though it's fairly, within those categories, fairly straightforward to think about, for example, again, 50 reports of a given type of a container or a medication, et cetera, is easy. But there's often actually contributing factors across categories, and our ability to do that analysis and create stronger connections between those is pretty limited right now.
Yes,
that's something that is an opportunity.
That is very fair, and actually, that's part of where I'm heading there. Just he's anticipating my next thoughts. No, that's it. You're doing great.
I guess it's obvious is this type of a system is good at detecting some things, but it's terrible at detecting other things like errors of omission and like more subtle things where we could be doing a much better job, but it doesn't show up as an event. And those are much harder to detect with this approach.
Well, If you give me a moment, I'm actually going to attend to that because I want to speak to that very specifically. So please hold that in the parking lot, as it were. Because I want to talk about another one of the listening posts that we use for this type of activity. And again, this is a mortality review process, actually, that I've been helping to lead for the last almost 2 years now. And the intent of this is to, again, find another signal to help us understand the way we're delivering clinical care to our patients and thereby find opportunities for improvement. We started this actually on hospital medicine in the attempt to really understand who were the patients we were taking care of and where were the opportunities in care delivery for us. And looked around the country to see where was this kind of work activity happening, because we found that there was not a consistent process or approach that was being uniformly deployed across the health system. So we began to adapt a model which is actually really provider-driven, and it starts with the patient's death, and again, this is limited to inpatient deaths, to Dr. Owen's point earlier, with the focus being once that patient dies, then the care team is the one who completes the reviews and helps us identify a subset of patients to look a little bit closer at, as well as to begin categorizing some more broad themes around complications or communication issues, teamwork, timeliness and delays, or end-of-life care. And that's given us a lens on this. I also want to make a note to highlight that this is part of a more comprehensive approach to mortality, that this is just but one tactic that we use that also includes a close look at the documentation and the administrative data and trying to pair this with other data streams, but I'm going to get to that in just a second. And over this time frame, since we put this in place and we went live across the organization in January, again, just for inpatient deaths, there were 1,221 deaths during from January to the end of September, of which this process was able to touch 83% of those deaths. And we've seen a lot of lessons learned from that. And again, at a really high level, we've been able to categorize general themes, that we have opportunities to really figure out better ways to transition our patients across the spectrum of care, particularly around the end-of-life activities, and how are we having conversations with patients about their goals of care and so on and so forth. And there's been a lot of focus and energy working with palliative care colleagues and otherwise to increase access that our patients have to those types of resources at the end of life. We've also seen some signals around communication, or delirium is actually one that has been a consistent theme, as something that is really having an impact. And we've been bringing together a group across the 3 hospital entities to say, is there a way to structure this and to start looking at a tiered approach to figuring out, can we prevent delirium when patients are coming in? Can we risk stratify if they're coming in for surgery or otherwise? And how do we identify and manage it when it develops? And these are the types of activities that we're using as a signal coming from out of this tool. I'll throw this up there, I'll throw it up here with caution just to say that, again, this is one strategy in a more comprehensive approach to mortality, and this is part of how we measure ourselves for the purposes of comparison to say, do we have room for improvement? And we use a risk model, which is derived from the University Health System Consortium, and without getting overly complicated, it takes into account both the observed deaths that we're seeing, who we're taking care of, and the expected mortality, and creates a ratio. And the expected mortality is really, are we accurately reflecting the severity of illness of our patients through our clinical documentation? And what I'll say is that as we've seen a lot of energy and focus, to Dr. Owen's point earlier, around that particular piece, and there's been a tremendous amount of energy, we've seen our expected mortality go up, which is a good thing in this case. But we've seen that our observed mortality still remains relatively flat. And so there's a tremendous opportunity to really understand what is happening with our patients. So getting back to your point, Dr. Granger, I'll say that we have multiple listening posts like this to understand the types of care we're delivering to our patients. And at a very high level, it gives us, again, just the tip of the iceberg around our clinical practices. And really what we need to start doing is looking at all of these listening posts or these signals from RL6, from our patient safety indicators, from the mortality reviews, from administrative, all of these types of signals to really bring them in to make them more to tell the entire story for the patients. Similarly, that will allow us, at the same time, that will give us hopefully some better power to predict and, again, prevent things before they happen and analyze the patterns of care that are happening. And it's harder for us to do that right now because we may not have the right resources in place to do that. I will say that we've also begun exploring some qualitative analysis of mortality specifically, but I'd love to see it extend to the safety reporting. A lot of the information we get in through this is free text. And is there a message or a signal in there that we haven't been able to capture? So again, these are some of the types of things where we think there may be a broader opportunity.
Just to continue to this path a little bit more, and then again look for some discussion towards the end here, is we have a couple other tactics we've deployed on the delivery side to again, back to Chris's point, to understand, what are opportunities to improve care delivery. And one of those is care redesign, and this is an example of already some collaboration that we've started with colleagues here, some who are here in the room, which is really to think about, how should we fundamentally redesign care delivery. And this conversation actually started about 4.5 years ago, frankly, when we were meeting with a payer. We were meeting with Blue Cross, and we're having some discussions with them at the time about new relationships between payers and providers. And as we looked at some of their internal data, looked at some of our analyses, it became clear that part of the message that we needed to receive was that it wasn't about contracting for different rates. It wasn't about some of the very tactical things in the past that had come up in discussions with payers. It was that we needed to take ownership as the provider community to fundamentally rethink how we delivered care, and that fundamental rethinking could be a dramatic change. It could be moving care to a whole different site of service, a whole different way of delivering care, a different treatment path, et cetera. It could mean subtle changes and focusing on an efficiency and new team-based care model, a host of different factors depending on what area we're looking at. But that fundamentally there were some probably 40 to 43 specifically, different areas that when we looked internally where we had evidence of unnecessary, or what we thought was probably unnecessary variations in care, outcomes that we were maybe not as pleased with, some of which might have been quality and safety, others focused on experience, access, and many focused on efficiency and cost. And so we created a paradigm for care redesign that launched about 4 years ago and initially targeted 20 areas that we were going to invest in to redesign. And by invest in, I mean surround engaged clinicians of all flavors, not just physicians, but all of our health professionals, with tools and teams and data to look at how care was being delivered and come up with a new plan. With a commitment that was made by system leaders at the time that if they came back with reasonable plans, we would support it 100%. And support it meaning investment in staff or time or new models, new locations, shifting care, in a couple cases investing actually in funding a clinical trial to answer a question that came up as a part of the care redesign. And I think we've held pretty true to this. I can only think of 2 things that have come forward through this process that we've actually not been able to deliver on when people asked us for a very specific request. So you see that the sort of future goal here of coordinated, value-focused, really patient-centered care. I don't really like the phrase hardwired, but it's been hard to find another word to use there, but basically designed for consistency and to reduce unnecessary variability. We started with a model that was reasonably effective, although very slow. And so our first 6 episodes that we worked on took an average of about 10 months each to do. We were doing them in parallel. We were doing 3 to 4 at a time. But it was clear that to get to our goal of 40 episodes, which we initially expanded to 20 to 40, that it was going to take, it would be the end of my career before we finished that, and that wasn't good. So we tightened this up and actually came up with the idea of being a little more focused, adding to our team with some different skills, and trying to tighten this up to a 24-week total time frame, 12 weeks of design, 12 weeks of implementation. And that's actually been very challenging. And our focus, as you see on the right-hand side in the new model, is still quality improvement, patient and care team experience, and waste reduction as a key driver for efficiency. And I'll show you some examples here of the newly designed model. We've actually are just launching the 5th wave of that. The results have been mixed, being honest. I would say that about half of the teams, first I would say all of the teams have responded back that the experience was very positive, that it was enabling, that it created connections across health professionals that didn't have a chance to interact in this way before. All of them also said it was tiring and it took a lot of time and effort, and it was being done on top of work we're already doing. So it took after hours and early morning time to do this. So I don't mean to minimize the impact on individuals and teams to do this. But most of the groups, I would argue at least 60%, actually really did achieve the outcomes that we had asked them to in the early phase, and we're seeing some real benefits from that, some of which we'll allude to. The other 40% of teams made some, slight progress, but we found it needs to be more of an iterated change management approach there. But to give you some sense of the kind of things, and again, you won't see things here that are rocket science, but around the spine clinical team initiative, so preference cards, which may not be that familiar to many folks in the room, but this is a list of all the equipment and supplies that a spine surgeon would want going in. So we had, when we started this process, we had, I think, some 23 spine surgeons, and we had over 100 preference cards. And the variability was dramatic. And that might not sound like an area to focus on, but in fact, in terms of safety and quality, having nurses have to work with very different sets of materials and tools from provider to provider, where, again, there was probably no need for that degree of variability, creates some risk, actually. It also creates inefficiency. It creates cost. So a series of these things you'll see there with a key theme that emerged not only in spine but in others, that preoperative risk assessment, although there's a lot of evidence about that and how to do that and how to mitigate it, we had not really implemented at Duke. And that we had a process that checked the boxes but probably didn't fully deliver on the real opportunities to enhance patients' characteristics in advance of a surgery. Sometimes that was about a failure to recognize. Often it was a failure to slow down and say, wait, doing the surgery next week probably isn't the right answer. Let's give the patient a month, let's help them quit smoking, let's help them do a couple other things, let's optimize a couple meds, and let's do the surgery, this elective case, in a month rather than in a week. So a series of things, and I could give many other examples. I will throw out about one from the heme malignancy group, which has really been focused on where we deliver care and trying to move patients out of the emergency room and deliver specialty, access to specialty level of care at off hours across this continuum of patients with hematologic malignancies. You probably all know, since many of you share a building with the Adults Bone Marrow Transplant Clinic, that they've done this for years in their cell therapy and bone marrow transplant program, where they deliver a very holistic program of care with 7-day-a-week access and after-hours access to really create a very strong care continuum and organization of care around these patients, and it achieves very good outcomes. So looking to replicate that here. So what we've learned, and we had initially a bunch of slides in here showing outcomes, is that first off, we can measure impact in the things we measure today. So fairly substantial reductions in many of these around readmissions and length of stay, improvements in patient experience, an average of about a 7% reduction in total cost of care. And no evidence of worsening of outcomes in terms of safety signal or issues like that. Also a marked uptick in team scores around work culture and quality and things like that. But what we haven't been able to do is measure some of the more detailed outcomes that the providers hoped we'd be able to coming through this. So patient-reported outcomes after things like spine surgery or other episodes, disease-specific outcome measures that might guide further intervention or might give us information about whether what we've done makes sense or not. So again, coming back to the need for collaboration and figuring out how do we measure things differently. The last thing I'm going to say is really related to population health, and I wanted to, first off, as John highlighted, one of the main areas of focus for us has been to prepare ourselves to think about delivering care differently, rather than being episode-focused or fee-for-service medicine focused, to think about patients and care more holistically. And I suspect many of you know this, but Duke's been on a sort of a gradual journey that dates back to the 90s through Community Care North Carolina and Northern Piedmont Community Care, which is a care management organization for Medicaid patients. And we're actually the only health system in the state that has owned and operated one of the 14 CCNC networks, which serves about 90,000 Medicaid lives. But over the last several years, we built out an infrastructure to help deliver care management and care coordination to our employees and their families. Duke has some 63,000 employees, family members, and retirees that we serve. About 43,000 of those are now in an insurance product through Duke that includes active management. Again, some of you have been a part of helping us. All the clinicians have been a part of that. Some others have been a part of helping us analyze and understand what changes should we make in our health plan and our benefits and our care management to improve care. But we've taken that experience and started to leverage it and basically learn more by participating in similar models of care with other payers like Coventry, now Aetna, Cigna, and then with CMS in the Medicare Shared Savings Program, where we have the largest Model 1 ACO in the state with some 47,000 lives in that product now. And what we're really doing now, which leads into the quality agenda here, is we've continued down this path with payers with a Blue Local exchange product that went live in January with some 9,000 lives in it. So giving us the total number of lives where we have some responsibility, some risk and some responsibility to think about care more holistically, to be about 240,000 lives. So of the 750,000 unique patients we serve, about a third of those, we now have some care coordination, some other aspects of care management responsibility for, and some at least limited financial risk. The other thing we've done in this time is think about partnerships that are necessary to be successful and to deliver adequate care within our communities. So I think, as many of you know, we launched one of these products with WakeMed and with their clinical integration network of physicians called Key Physicians. And we're in active discussions with several other health systems about how we could create regional collaboratives. What's interesting about that, and part of the reason to highlight it here, is not only does it change the focus to be from episodes of care to analytics across populations, it changes the focus to be more predictive rather than reactive. The goal being to really achieve some of our goals, we need to be working with patients who we know we will care for over a period of time. That's the first prediction, in ways that help improve their outcomes, lower their cost, improve their experience over the period of time we expect to care for them. So there's actually a fair amount of technically challenging, although Leslie, who I don't think is in the audience, tells me that it can be done, but analytics that we don't currently have the capability to do. And as I was saying to Uptal before this, we're being inundated with folks who want to sell us those services, who want us to use a vendor model for these sort of analytics. And many of us are asking the question, how could we build that sort of capability within a population health sciences center, within the analytics teams and resources that we have now, and we've had some great discussions about what that future might look like. This is actually our clinical integration network, just so that again, thinking about the scale and scope and where we might look at care. We have about 1,600 physicians in our clinical integration network called Duke Connected Care, and I share this slide in part just to say that as many of you know, so Lincoln Community Health Center is not only in our clinical integration network, they are in our electronic health record. And so we have a unique opportunity to be able to look at clinical data fairly holistically across Durham County with the health system, the PDC, and Lincoln all using the same electronic health record. So that really takes us to sort of future directions, where we'll kind of wrap up on this slide and then have some time for conversation.
So that was just, again, a high-level view of some of the key tactics and strategies we've been using. And now, as we have said, that we want to talk about where are we going in the future. And you've heard a lot of us talk about continued partnership and the opportunities to grow, how we measure ourselves and predict and care for a broader population of patients. This is just some of the key highlights that came out of the strategy, the planning for the next wave of this. And you can see a lot of those themes reflected here. We really want to be a leader in clinical outcomes and patient safety and really deliver that to the highest degree. There's a number of emerging recommendations that came out of this work, which included that we really wanted to figure out how do we continue to engage not just our providers but our patients in this work. How do we create a clear and coordinated path for this type of activity? And that's not restrictive to the clinical enterprise. That's part of what we're describing is we're identifying areas where we want to have a greater analytical lens or a predictive lens. How do we develop some of those partnerships? And at the same time, figure out ways to prioritize and resource, and how do we bring that systemness to integrate all those together? And part of this is one of the final recommendations is how do we then communicate and take that back to our providers and to our patients and deliver on that promise of quality excellence that we have been harping on. You can advance the slide, actually. So I think this is really just a slide to segue us into kind of an open conversation and dialogue, and certainly we'll take questions. Just to say that, I think, as we look outward over the next 5 to 10 years for quality at Duke University Health System, there are tremendous opportunities to start being more proactive, to take the excellent platforms we already have for delivering quality to a tremendous number of patients in the area, and the 750,000 unique lives and growing that we're taking care of, that opportunity really exists to grow that. But it's going to take more people and more partnership at the table to figure out what are the measures, how do we do this, how do we really turn some of the resources we have together but maybe haven't brought together in a true system way to move forward. So with that, we'll pause and open up the floor for questions.
Yeah, this is great. So thanks for coming over here, coming back to North Pavilion. I'd say kind of a whole bunch of this agenda is really exciting, maybe overdue, but the two pieces I'd push out. One is, one of your comments was really interesting. So with all these micrometrics, the perception of the quality of care here at Duke is not high. And if you've ever referred a patient to Duke, you know what that means. So yeah, we'll tick the box in Epic, but you know the chance of you getting the right provider and getting through the process of care longitudinally is very, very low. And so how do you kind of reconcile those things over time? And then entirely separately, I guess maybe this is for Tom. Why has this been so hard? I mean, where is the intellectual leadership for this going to come from if using other people's metrics and strategies don't work and we have to create our own? How are we going to do that?
Ooh, I'll take the easier of the two difficult questions. I think the point of my comment was more to say that there are a lot of things we do really well here. We actually have a robust process for measurement, which when we've talked to other organizations, that actually our data collection and our performance improvement is really strong. I think that is the way I took that lesson when we had our strategic planning group with providers across the organization. They said, we don't feel like our quality is high. I think was more a reflection of two things. One is that we probably haven't been as great in communicating all the things that we do. I think there's been a strong operational focus, at the hospital or at an individual clinic, but translating all of this type of performance out to the individual folks is tough. Has been where we've had an opportunity to grow, and certainly I think is one of the big pieces of what we are talking about here related to a culture of engagement. How do we take the things that are working really well and make people aware of what we're doing and help that to grow on that? The other part of that too is kind of the idea of where the work happens, and I think that's another area where people feel like there's lots of measurement, but we don't necessarily know how to turn that measurement into practice change. And so I like to think that the feedback from that group was more related to the fact that we're really self-critical and that we see all these areas of opportunity but haven't been figuring out a way to realize them. I get the sense that these are struggles that other organizations have, and I actually think it is a real powerful testimony to how we have a strong focus on quality and continue to push that envelope. But I will let Tom comment, and then
I think that's fair, and I think there are several different ways we could interpret it. It's interesting. I got a call actually on Thursday of last week from the Statistical and Analytics Manager at UHC, the University Healthcare Consortium, which is the 124 or something, academic health systems in the country, asking if we'd be willing to meet with a group of other folks that were interested in some focused improvement on quality, because we've actually been noted for several years now for our overall quality measures. I think your second point though is the most important part here, because we may do really well on some of these measures, and we do actually. We rank as one of the best health systems in the country with many of these measures, but I get 3 calls a week for how can I get in to see this doctor? How do I navigate this? We know that we're difficult to do business with, and that there's a lot of things that we don't measure very well that actually substantially impact care delivery, impact experience. And we know those things, and we need to act on those. And we didn't talk at all about access, and we didn't talk about consistency across the institution. And your point about why is this so difficult is one I ask my wife every night. No, I ask often. I ask often. Are we? What is it? Are we unique in that it is so difficult? And to John's point, when we talk with colleagues around the country, I don't think we are specifically unique. But there are clearly some things we could do to make it easier for us to achieve what we've laid out here. Some of that is probably about how we're organized, although we spend a lot of time focusing on that. I think that gets to be an excuse. That's part of why we were excited to be here, though, because when we found conversations with folks, as recently Michael talking about care redesign and how, when we start to create some, identify the areas of overlap and synergy, we can actually get a lot of things done and use those test cases to then build new models for collaboration. Sometimes that is funds flow. Sometimes that is, creating an organizational priority and investment. Often it's just awareness and creating an intersection and collaboration. And I think your comment is spot on, Kevin, that this is overdue. Although we've done some good things, that we probably should have been thinking about this some time back. So your comment about where the intellectual leadership comes from, and I think this is where I wish Eric was here. Actually, this is where Eric and I have had some really good conversations about how do we stimulate that kind of discourse that needs to happen not just in a large room like this, but needs to happen very regularly with thought leaders who are developing evidence, who are analyzing care delivery patterns outside and inside of Duke, people on the ground who are delivering care of all skill levels, not just physicians. And we need to create some stronger, not just signals through voluntary reporting, but opportunities for those people to kind of raise their hands and recognize what we need to do differently. And I think, again, we've made some progress towards that. The care redesign teams have been one example where that really seems to happen. And you know, the challenge there is scaling it, and that approach only takes you so far because it is focused on specific areas. But
let me just also thank you guys for being here, and I completely agree that that where we need to be is to be more proactive than reactive. Like, a lot of these quality metrics are important, but they're the tip of the iceberg. And every one of us knows, 50% of people in the Duke Health System who have AFib and risk factor for stroke are on an anticoagulant, based on Anne-Marie Navarre's work. In 2010, 17% of people in the city of Medicine got bystander CPR, compared to 40% in Seattle. Duke is the #1 employer in Durham County. There are hundreds of these things. So I think the most important thing is kind of the culture that you talk about of quality and resourcing people to be, including people like in the DCRI who think about this every day, to how can we work together to bring us to an environment where we're more proactively focused on optimizing healthcare. But being here is the key, so thanks.
Thank you. Thank you.
So I just want to thank you both for starting what I hope is a very long and productive conversation. So thank you very much.
That's good, man. I'm a man.